Hello and welcome back. Today we'll be talking about an approach to peripheral edema. This will be the third part in our series on an approach to peripheral edema. Specifically, we'll be discussing regarding nephrotic syndrome. Okay, so we discussed that peripheral edema can be the result of these four processes. That is, it could be the result of decreased urine output resulting or RAS activation resulting in increased total intravascular volume. It could be the result of a proximal obstruction to the hepatic vein that is proximal to its drainage in the IVC. Okay, it could be an obstruction to the hepatic vein distal to its obstruction or rather entry into the IVC, and it also could be due to decreased serum albumin. Okay, so going ahead. Pedal edema due to decreased albumin is therefore due to, as we've already discussed, decreased production of albumin secondary to nutritional deficiencies or hepatic cirrhosis, or it could be due to increased loss of albumin. And albumin is lost either via the kidney through something that called nephrotic syndrome, that is our district point of discussion today, and or through protein losing enteropathy. Okay, so this will be our discussion for today. Cirrhosis will be discussed under an approach to ascites, which is an upcoming series, as portal hypertension often precedes abnormalities in hepatic synthesis, hepatocyte synthetic dysfunction. Uh, so, and the other thing is that protein losing enteropathy will be discussed under an approach to chronic diarrhea. Now we'll talk about how peripheral edema due to decreased oncotic pressure occurs in nephrotic syndrome. So the first step to this will be to understand the two general mechanisms of glomerular damage that result into slightly different and relatively mutually exclusive clinical presentations. The second thing that we'll do is we'll understand how we quantify urinary protein loss clinically. Then we'll understand the three classical forms of glomerular damage that correlate with the clinical presentation of nephrotic syndrome. This will include membranous glomerulonephritis, glomerulonephropathy, to be more accurate, minimal change disease, and focal segmental glomerulosclerosis. So these are the topics that we'll be discussing today. And jumping right into it, so we've got two types of clinical presentations that can happen when there is glomerular damage. Okay, both actually result in edema, but the mechanisms are different. So in nephrotic syndrome, there's a loss of the glomerular basement membrane's ability to prevent filtration of proteins. Okay, whereas in nephrotic syndrome, there is actually an obstruction to renal blood flow within the glomerular capillary bed, which results in decreased glomerular filtration. There are other factors such as a decreased RAS activation due to epithelial injury. We'll get to that when in the details of nephrotic syndrome in the discussion. You know, to one discussion after the next discussion. Okay, so typically, this coincides with a significant structural damage to the endothelial glomerular basement membrane podocyte barrier, resulting in loss of RBCs in urine, along with protein and WBCs, not EBCs, WBCs. So the clinical presentations now in nephrotic syndrome, because so much protein is being lost, the oncotic pressure decreases, and as a result, the patient develops edema. In nephrotic syndrome, due to increased hydrostatic pressure, the patient develops edema. Now, because protein is being lost in urine, the liver has to start producing more albumin, and along with albumin, it ends up producing other proteins that it normally produces, like your lipoproteins, resulting in mixed dyslipidemia. Now, often with proteinuria, you lose lower molecular weight proteins more easily. So, the anticoagulant proteins happen to be slightly smaller in size, especially as compared to your fibrin and fibrinogen, fibrin, and thrombin. So, as a result of that, you end up developing a imbalance between anticoagulant and procoagulant proteins, favoring procoagulation, and therefore you end up getting a prothrombotic state. Now, in case of nephrotic syndrome, because of this increased total body water in an intravascular volume, there is an increase in blood pressure with oliguric renal failure because, as we've just discussed, the glomerular blood flow, capillary bed is obstructing flow. Now, when damage leads to proteinuria, we formalize urinary protein loss using certain parameters. So we can actually measure the 24-hour, amount of albumin lost in urine in 24 hours. You collect urine for 24 hours, the details of which are important, and I would suggest you read that up. And or we do this, and or we check the ratio of albumin to creatinine, creatinine being a marker of filtration. Okay, so the normal 24-hour urine albumin is just 8 to 10 milligrams. It's milligrams. Okay, uh, then we have an entity called microalbuminuria when we have up to from 30 to 300 milligrams of protein loss in 24 hours of urine, and then we have proper proteinuria where we have more than 300 milligrams of albumin being lost in urine in 24 hours. The creatinine albumin creatinine ratio for normal is less than 30, microalbumin is 30 to 300, and proteinuria is more than 300. The numerical values are the same, so it is easier to remember. Now, with normal, dipstick is a semi-quantitative way of assessing proteinuria. So the dipstick shows is negative in case of no proteinuria or 8 to 10 milligrams. It is absent or 1 plus, often called trace. In case of microalbuminuria, it is traced to 3 plus in case of proper proteinuria, depending on the exact amount of proteinuria. Okay. Now, again, the 24-hour total protein can also be assessed, and for that we check less than 150, absent to 150, and more than 150 milligrams. Now, based on now there are three histopathological entities that that correlate with the clinical diagnosis of a nephrotic syndrome. Okay, and yeah. So the thing is that although we use a biopsy to classify patients formally, the selectivity of proteinuria, that is what protein exactly is being lost, okay, can give us an idea as to what is the cause or which of the three types of histologies is most likely to be responsible for this particular patient's proteinuria. So we use something known as selectivity index. That is basically a ratio of urinary immunoglobulin G, that is this, to serum immunoglobulin G. So how much that is your gamma globulin, immunoglobulin gamma is being lost uh, in comparison to transferrin. Okay, so transferrin being a relatively larger protein is not lost that easily. So we check the ratio between these two. Okay. Now, if the protein loss is very, very selective, okay, what will end up, pardon me, transferrin being a smaller protein was lost very rapidly. So, if you have your very selective proteinuria, so you will lose transferrin, but you will not lose immunoglobulin. Okay, immunoglobulin are quite large in size. So, as a result of that, the ratio is less than 0.1. That is, for every 10 moles of transferrin being lost, one immunoglobulin mole is being lost. Okay. Now, intermediate would be 0.1 to 0.2, and non-selective would be more than point 0.2. Okay. So, this highly selective proteinuria is characteristic of childhood minimal change disease. Okay. Intermediate and sometimes highly selective can occur in adult minimal change disease. Um, Now, non-selective and intermediate proteinuria occurs with the other three entities, that is FSGS, membranoproliferative gene, and amyloidosis. Okay, and membranous actually can range from being highly selective to not being that selective. All three are possible. Okay, so with membranous, like with based on selectivity, really cannot diagnose membranous, but highly selective proteinuria essentially, makes FSGS or membranoproliferative GN very unlikely, as you can see here. Okay, it is not going to cause selective proteinuria. Similarly, highly non-selective proteinuria makes minimal change disease very unlikely. Okay, so that is how we see it. So if the ratio is more than 0.2, then it is very unlikely to be adult MCD and very, very unlikely to be childhood MCD. And if the ratio is less than zero point 0.1, then it is very, very unlikely to be FSGS or membranoproliferative gene or amyloidosis. Okay, so this is how we quantify it. Now, coming to the first histopathological entity, we'll go into the histopath of this in the next discussion, which is rather interesting. But first, we need to discuss the clinical concepts behind it. So, getting right into it. So, what exactly happens in membranous GN? So, in membranous GN, basically, there is either an abnormality of immune resolution, and you may have heard me saying this in the context of IgG4 related disease. Something very similar is happening. Okay, so there is an increase in serum IgG4 levels. Okay, more common. Sometimes there is a proper autoimmune response resulting in increased IgG1 or IgG2/IgG3 levels. Okay, and the different subtypes of immunoglobulin G will be discussing in a discussion on immunology later. Now, what happens is this complex of immunoglobulin G Okay. Plus its antigen goes and gets deposited in the glomerulus. And where it does get deposited in the glomerulus? If this is the basement membrane, and this is the endothelium, and this is the podocyte, it gets deposited here. That is in between the podocyte and the glomerular basement membrane. So that is what happens. Okay. Now, so there is a deposition of a subepithelial deposition of this particular antibody that is targeting a specific antigen. Now, IgG4 complexes, once they get deposited, see, IgG4 cannot under normal physiological concentrations doesn't really activate classical complement much. However, it does activate the mannose binding lectin pathway and activates complement. IgG1 and IgG3 both activate classical, IgG1 more than IgG3 activate the classical complement. And once you have activation of the classical complement pathway, the epithelium, there is the classical complement pathway eventually results in the production of MAC. Okay, so there is deposition subepithelially here, and that deposition of results in production of complement, and that complement then produces membrane attack complexes which get inserted into the podocyte. Okay, now, once they're inserted into the podocyte, that causes calcium entry into the cytoplasm of the podocyte. That results in two separate phenomena that occur. That is podocyte dysfunction and an oxidant-antioxidant imbalance at the within the podocyte. And podocyte dysfunction perpetuates even more oxidant-antioxidant imbalance because podocytes are the primary producer of antioxidants in that particular region. Okay. So now once there is podocyte dysfunction, podocytes are also what produce the basement membrane, and they are one most importantly, they are the ones that secrete the enzymes that are responsible for maintaining carbohydrate moieties that are attached to the glycoproteins in the glomerular basement membrane. So as a result of that, what ends up happening is the glomerular basement membrane ends up losing its charge. Now, the glomerular basement membrane has holes of around 7 to 8 microns in them, and albumin on average has got a diameter of only 3 microns. Okay, so normally if there is no charge in the glomerular basement membrane, albumin can be filtered through these holes within the glomerular basement membrane. So now, but because of the negative charge that it has, and it is able to repel negatively charged albumin under normal circumstances. But if it is not adequately silinated, that is, if the adequate amounts of glycoprotein chains have not been attached to these proteins, then you start losing protein. And this kind of proteinuria would be relatively selective. Okay. Now, the more the damage that is occurring to the glomerular basement membrane, the larger the holes that will be there in the glomerular basement membrane, and that will result in loss of larger and larger protein. So the non-selectivity of proteinuria will increase. Okay. Now, another interesting thing that happens is when there is podocyte dysfunction, there is a release of some second wave, quote unquote, antigens from the dysfunctional podocyte. And these are not normally, this is not something that the immune system trains our T cells to not detect in the thymus. So because of that, you end up producing serum IgG1 and IgG2 and 3, against these particular antigens. And these antibodies then these include superoxide dismutase 1, anti-aldolase and anti-enolase. These are all going to go and inhibit those specific enzymes. And those specific enzymes are actually again going to perpetuate more imbalance between antioxidant and oxidant. So the oxidants increase, that is reactive oxygen species increase, and the enzymes that neutralize these reactive oxygen species decrease. Okay, so this perpetuates more and more non-specific proteinuria. Okay, now membranous GN. So that's why I said, see, membranous gene can have selective proteinuria, it can have non-selective, it can have somewhere in between also. So the selectivity doesn't really help us differentiate membranous gene. Now, based on etiology, we divide membranous gene into primary and secondary. Okay. Now, the target antigen in primary, classically at least, since it was described in 2014, was considered to be M-type phospholipase A2 receptor, plateau receptor. Okay. Most cases were ascribed to that. Around 10% of those cases, of the other cases, were against a protein called thrombospondin domain 1 like 7A. Okay. Both of these were were immunoglobulin IgG4 antibodies that were targeted against these two antigens that are normally present in the glomerular basement membrane. So the clinical features of this were, 4 out of 5 patients had non-selective nephrotic range proteinuria. Sometimes there was microscopic hematuria, but this was less common than in FSGS. So if you have an MCQ question in which FSGS is an option or IgA nephropathy is an option, then microscopic hematuria would be much more common in those two as compared to membranous. But membranous can have microscopic hematuria. And the clinical outcome of these patients was actually highly variable. So one third of patients developed spontaneous remission, around one third have persistent proteinuria, and we'll discuss in later discussions in this series how that results in that can in certain cases result in progression to chronic kidney disease. Now, the thing is, plateau-receptor or thrombospondin domain like 17A antibody positivity does not exactly rule out secondary NGN. Okay, this is a misconception that people have. And actually, it can also be seen in a membranous gene that occurs in two important diseases, that is sarcoidosis and HBV. Okay, and it can be a part of paraneoplastic membranous gene. So, actually, as per KIDGO, all patients need to be evaluated for secondary causes of membranous, regardless of whether or not they are plateau or thrombospondin domain 1 like 7A antibody positive or not. Okay. Now, what it does determine is actually the prognosis. Like I said, generally when you take membranous GN, it is one by third, one by third, one by third. One by third resolve spontaneously, one by third continue to have proteinuria, one by third continue to have proteinuria and progress to CKD. Now, these patients can then be, we can predict who will progress to CKD or who will not based on their serum plateau receptor antibody levels. So the higher the plateau receptor antibody levels, and RIU stands for radio unit. So that is, we're going to do a radio immunoassay. If it is more than 150, that is highly predictive of progression to CKD. Again, the more non-specific the proteinuria, the more likely it is that the person will have progression to CKD. And again, because of that, as the condition worsens, more and more immunoglobulin loss will occur. And if it is more than 250 international units per ml, and the urinary IgG by serum IgG ratio to the urinary transferrin to serum transferrin ratio is more than zero point 0.2, these are highly suggestive of progression. So these are prognostic factors that have been included presently in our evaluation of membranous CN. Now, the thing is, there are other newer antigens that have been subsequently described since 2020 or so. Uh, Now, I have been exposed to this because me being a clinical immunology and rheumatology specialist, I I know about exhaustion 1 and 2, and there are others. So let's just discuss them and get it over with. This discussion will be a little factual, and I don't really like factual discussions, but these are common questions in in entrance exams and targeted towards your postgraduate and super specialty exams. So we need to cover them nevertheless. So how I remember this is exhaustosis 1 and 2 is very, I think everybody knows that is SLE. The other three are NPS, okay, or PNS, peripheral nervous system. So uh, P stands for Procalcitonin 7, N stands for NELL1, NEL1, and S stands for SEMA3B. Okay, so it's SEMA4. We'll be discussing that in neoangiogenesis during our discussion on immunology. Now, these four antibody types have very specific associations. Okay, so exhaustion 1 and 2 antibodies first of all occur usually together and occur in SLE patients. So they much more commonly occur in ladies than they occur in men. So the male is to female ratio is 1:4. The mean age at diagnosis is quite young, that is 36 years. Okay. Now, NEL1 is almost equal, male is to female, 1:1, and the just reverse the numbers. That is 63 years is the mean age of presentation of patients with NEL1 antibody positivity. Procalcitonin is the reverse of exhaustion in terms of the male-female ratio. So it is 3 times more common in men than in women, and also occurs in older people. Okay, and semaphore and 3B, again there is a nice symmetry there. So 6.3 is to 3.7. Okay, so if when we discuss sarcoidosis, we'll discuss how the male-female ratio is 43 to 57 in some data. So again, there's an asymmetry there. There's an asymmetry here. Together they form this. This will give you 10 if you add the two numbers up. Okay. Now again, semaphore and 3B actually occurs in children and young adults. Doesn't usually occur in older people. Whereas NEL1 and procalcitonin 7 typically occur in older people. Now, the clinical correlates of this are that exhaustion 1 and 2, as I just discussed, in 30 to 35% of class 5 lupus nephritis, it is present, and there may or may not be concomitant proliferative glomerulonephritis, that is class 3 and 4 lupus nephritis along with it. Now, it also correlates with positivity of two other autoantibodies associated with systemic autoimmune disease. This includes RNP, like you would get with MCTD, that is mixed connective tissue disease, anti-Ro and La, and anti-dsDNA. Okay. Now, NEL1 is a malignancy associated marker. So, normally, like we just discussed, your thrombospondin domain 1 like 7A and plateau receptor antibody positivity doesn't really indicate malignancy, although it could. Okay, but usually it doesn't. Nil one is a death knell. Okay, so it's a death knell because it often correlates with the presence of a malignancy. But this is often means around 10% to 33% of patients. Now, procalcitonin 7 antibodies are actually quite good prognostic because they're not typically associated with malignancy. Uh, but again, there is some data that counters this also, and we'll come to that. Okay, and semaphorin 3B typically occurs in membranous gene with a hereditary predisposition. Okay, so there will be a positive family history. Now, in a subset of patients. Now, exhaustion 1 and 2, you will not find these antibodies in serum. So, this is only in the lupus nephritis biopsy. Okay. NEL1, procalcitonin 7 and semaphorin 3B, you find in the blood. Now, NEL1 is not detectable in reducing conditions. That means basically if I add some reducing agent into the serum before I test it, it will no longer be detectable, whereas semaphorin 3B is detectable in reducing conditions. Now, IgG subtype, exhaustion 1 and 2 as well as NEL1 are IgG1. Now, please remember that your the most commonly described antibodies in membranous, that is your plateau receptor and thrombospondin 7 like 1A are IgG4. Okay, this is IgG1. Now, procalcitonin 7 is again IgG4. Okay, and semaphorin 3B are IgG1. So, of the new antibodies, only one is an IgG4. Of the old antibodies, both were IgG4. Okay. Yeah. Now there are two other target antigens that have been described in SLE membranous nephropathy, other than exhaustion. Actually, not two. There are five others. Okay. Uh, so I use a mnemonic, that is I must vent because I get frustrated and it's boring to remember this. So all are IgG1 IgG1 subtype, just like exhaustion 1 and 2. Otherwise, unless I specify otherwise. Okay. So what does must vent stand for? M stands for must stands for MST, that is macrophage stimulating protein 1, which is IgG1, but can also be IgG4. Then V in Vent stands for Vazorin. Okay. E stands for early endosomal antigen 1. N stands for your neural cell adhesion molecule, and T stands for TGF beta receptor 3. Okay. Now, importantly, TGF beta receptor 3 can be any IgG subtype, including 2 and 3. Okay. And finally, we also have an anti-fecolin 3 antibody. Okay. Cannot be seen in my feed, but anti-fecolin 3 antibody may be there, but we don't really know. It is a possible thing. It's not a clear association as of now. Okay. Now, procalcitonin 7 antibodies may be IgG4 and IgG1 or IgG4, and it is commonly associated with one, malignancy, which is in 21% of cases. Now, I just said that it is not associated with malignancy, okay, but sometimes it is. So, it is less so, and the death knell, that is NEL1 antibody positivity, it is in 21% cases, it is associated with that, and autoimmune disorders are associated with procalcitonin 7 antibody positivity in 14% of procalcitonin 7 antibody positive patients. Okay. again, I said a lot of facts, and you can just, maybe take a screenshot of this and recall it. Again, they like to ask you factual questions, so what can I do? Okay. Similarly, there now, see, if I ask you this question, the next question I would ask is, like Procalcitonin 7, is there any other antibody that occurs in older people but is not associated with malignancies? So that is HTRA1. Okay. And HTRA1, importantly, the serum levels correlate with disease activity, just like your plaque receptor. Okay. Now, Procalcitonin 7 is a podocyte antigen. Now, another podocyte antigen that has also been described in primary GNA is Netrinmab. The name is a little unusual, so I think you'll be able to recall this. So this is a very high yield table, okay, and it's something that you need to be aware of. Okay. Now, again, Netrin1 also shows correlation with disease activity. Okay. Now, of this, it is sometimes difficult to remember which are the IgG4 antibodies and which are the non-IgG4 subtype antibodies in membranous GN. So I use the mnemonic TEMPTS. Okay, it tempts you to remember. So T stands for TGF beta receptor 1. E stands for exhaustocin 1 and 2. M stands for your macrophage stimulating protein 1. Stimulating one. P stands for your Procalcitonin 7. Again, the T stands for here it is HTRA. So TRA is what you should remember, and S stands for semaphorin 3B. Okay, so that's how you remember this. There's a lot of facts on this one particular slide. You'll have to go through this a few times before you're comfortable with the facts. Now, some autoantigens in membranous GN occur in very specific clinical context. Okay, so what are these? This includes anti-contactin 1, anti-neural derived neurotropic factor, anti-PCSK9, that is proprotein convertase subtilisin slash kexin 6. PCSK9 is what we inhibit in for hypercholesterolemia. We'll come to that later, and anti-fat one. Okay. So contactin 1 antibodies you may have heard of in chronic inflammatory that is demyelinating polyneuropathy, that is CIDP cases. So here a small proportion of contactin 1 positive CIDP cases develop membranous shield. Now, neural derived neurotropic factor antibodies have been described with syphilis related membranous gene. Anti-PCSK6 antibodies have been described with NSAID usage. One important thing is neural-derived neurotropic factor in syphilis is not associated with IgG4. Okay, which is a slightly interesting thing because IgG4 is associated with histological presence of plasma cells, and syphilis is associated with histological presence of plasma cells. But in IgG4, obviously you get IgG4 antibodies. In this, you do not. Okay. Now, lastly, anti-phyton antibodies developed post-hematopoietic stem cell transplant, and that is something that uh, it is a factual question that can be asked. Okay. Now, coming to what are the causes of secondary MGN. So, till now we've been discussing antibodies associated with primary MGN, which is a renal limited autoimmune disease. Okay, which may or may not be associated with a malignancy. Now, but usually is not. Now, the associations of secondary membranous GN are practically endless. It's a long list. So that includes systemic autoimmune disorders, practically all, but specifically RA, sarcoidosis, Sjogren syndrome, IgG4 related disease in SLE. Then systemic autoinflammatory disorders that includes your spondyloarthritis, including ankylosing spondylitis, and vasculitic disorders like giant cell arteritis. Now, organ-limited disorders, again, there are practically endless number. Uh, what is it been described in Harrison is for nervous system, it is myasthenia gravis and Guillain-Barré syndrome. For hematological, it is pernicious anemia. For thyroid, it is Hashimoto thyroiditis and Graves' disease. Dermatological, it is dermatitis herpetiformis and bullous pemphigoid. And for GIT, it is Crohn's and primary biliary cholangitis. Okay, and I really hope people don't ask you these questions because these are really, that it's just an association. It's not really causation. Okay. Now, again, malignancies, a long list of malignancies can cause this breast, lung, gastric, colonic, melanoma, mesothelioma, pancreatic, prostatic, esophageal, your neuroblastoma, ovarian, oropharyngeal, and renal. Okay. then including benign. Now, this is something that is a little odd, so you have to remember that. Okay, so that includes hepatic adenomas, your adrenal ganglioneuromas, and schwannomas. Okay, this is something that again is a little odd, so may be asked. And among infections, practically any chronic infection can cause it. But one thing that one must remember is not just malaria, kala-azar, and leprosy. It is also and syphilis. It is also schistosomiasis and filariasis that are associated. Okay, and we just discussed with syphilis, it is your anti-NDNF antibodies that we get. Now, last disorder I use a mnemonic that is Dushman because I get tired of remembering it, and this is my Dushman. Dushman in Hindi means enemy. So D stands for diabetes, U stands for urticarial vasculitis. Interestingly, I recently had a patient with, with the hypocomplementemic urticarial vasculitis syndrome who had nephrotic range proteinuria, but actually the patient's biopsy showed uh, crescentic GN because it was actually a HUVS, that is hypocomplementary urticarial vasculitis syndrome, and we'll come to that in our discussions on SLE, so autoimmune disorders. So S stands for sickle cell disease, H stands for hemolytic uremic syndrome, M stands for myelodysplasia and mastocytosis, A for alpha 1 antitrypsin deficiency, and D for diabetes. And I know I have mentioned diabetes twice, but that is because diabetes is by far the most common cause of any type of renal disease. Okay. Now, finally, secondary MGN can also be due to drugs, and I use a mnemonic that is CLAMP. C stands for clopidogrel and captopril. Important because we often give ACE inhibitors ARBs for decreasing proteinuria. Okay. Now, L stands for lithium. A stands for something that I give routinely, that is anti-TNF inhibitor therapy. Now, importantly, again, ankylosing spondylitis long-standing can cause amyloidosis because it causes proteinuria. You give anti-TNF for a long time, that is also associated with membranous change. So M stands for mercury, which we don't give; it's a toxin. And P stands for usage of penicillamine. Again, we don't really give penicillamine now. And probenecid. Now, coming to minimal change, this is actually a very short subsection of this topic, so you'll be glad to hear that. So here, there is an alteration in T cell functioning um, in terms of expression of CD80 and CD40 ligand. Okay, and that secondarily causes podocyte effacement, and because there is podocyte effacement, that is, the podocytes are no longer attached to the basement membranes. There is highly specific there is loss of that negative charge that we discussed on the basement membrane, and there is highly specific proteinuria, which with urinary immunoglobulin by transferrin ratios being very low. Okay, so that is that. Now, there are very few secondary causes of membranous GN. One that everybody knows is leukemia. Okay, but it's also associated with rain. Okay, because if you are getting a secondary cause with minimal change disease, you are stuck in the rain. Okay, so rain is R for rifampicin, A for atopic disorders, I for interferon alpha beta, and N for NSAIDs. So this atopic disorders and NSAID usage, okay, we can expect with anything, but the association with atopic disorders and with leukemia is something that is important to remember, and obviously rifampicin while treating for tuberculosis. Okay, now we've understood the general mechanisms of glomerular damage that result in these two different clinical presentations. We've understood how we quantify protein loss in urine clinically. We've understood the three classical forms of nephrotic syndrome, of which we've discussed in detail membranous glomerulonephropathy. We've discussed in detail minimal change disease. Now we're going to discuss focal segmental glomerulosclerosis. Okay. Again, this is a description of the histopathology of the lesion. Okay. That the term is a description. So I'm going to first discuss the clinical aspects of it. And then in the next discussion, we'll get to exactly what it is FSGS and why when we call it FSGS. Okay. Now, basically, what you have is there is loss of renal glomeruli. That can happen due to increased body weight, that is obesity. It could be a primary glomerular disorder. It could be a secondary to a systemic disorder like diabetes or systemic hypertension, because of which there is decreased perfusion of the macular densa of the nephrons that have been partially damaged by the systemic disorder. Okay, now or the primary glomerular disorder. Now this results in activation of the intraglomerular short feedback loop. So the macular densa is so in your glomerulus. say this is the glomerulus, and this is the opening of the glomerulus. You got an afferent arterial and you got an efferent arterial. Okay, and the tubule rotates in case of the juxtaglobular, corticomedullary junction nephrons, rotate such that it ends up coming in between these two, and this tubule part is called the juxtaglomerular apparatus. Okay, so since it is right next to the efferent as well as the afferent arteriole, it can, through local mediators, release of local mediators, maintain the tone of these two structures. Okay, so activation of the intraglomerular short feedback loop actually results in constriction of the efferent arteriole and dilatation of the efferent arteriole. So there is decreased uh, blood flow into the glomerulus and increased blood flow out of the glomerulus, resulting in decreased hydrostatic pressures within the glomerulus, and that results in decreased GFR. Okay, so that is one thing that happens. Now, let's go ahead with the next thing. So we've got decreased perfusion of the macula densa of the partially damaged nephrons, resulting in activation of intraglomerular short feedback, also resulting in RAS activation. Okay, so now RAS activation has some interesting effects. One is that RAS generally in the blood, in the systemic circulation, causes increase in blood pressures, and it causes efferent arteriolar constriction. So now again, we'll draw the glomerulus. This is the glomerulus. This is the efferent. This is the efferent. Now the efferent is contracting. Okay, the efferent arteriole is contracting. The afferent arteriole is staying the same. So because of that, now there is an increase in the intraglomerular pressure. Okay. Okay. So let's discuss the mechanisms of focal segmental glomerular sclerosis. We have loss of renal glomeruli due to any reasons, maybe related to obesity, maybe due to a primary glomerular disorder, maybe due to a systemic disorder like diabetes or systemic hypertension. Because of that, over a period of time, there are some nephrons that are damaged, and in those nephrons, the glomerular filtration rate is decreased. Now, along with that, there is activation of the intra glomerular short feedback loop. So what does that? That is basically when you have a glomerulus, say this is your glomerulus, there is an afferent arteriole going into the glomerulus and there is an efferent arteriole coming out to the glomerulus. Okay, and in between that, in the corticomedullary junction glomeruli, you have got a tubular cell passing in between. Okay, so these tubular cells form what is known as the juxtaglomerular apparatus, or the GGA. Okay, and through production of local mediators, particularly nitric oxide, it is able to induce dilatation of the afferent arteriole, and that dilatation of the afferent arteriole results in increased blood flow into the glomerulus, resulting in increased filtration or increased hydrostatic pressure within the glomerulus, resulting in increased filtration. Okay, so that is your short feedback loop. The long feedback loop is what get activated due to decreased perfusion, that is due to production of your renin, and that release of renin results in RAS activation. RAS activation then in turn increases the systemic blood pressure. Now, along with the systemic blood pressure, it also causes efferent arteriolar constriction. So again, this is the glomerulus. This is the efferent arteriole. That is afferent arteriole. That is the one that is going towards the glomerulus, and this is the efferent arteriole that I've drawn in green. These are the epithelial cells in between. Okay, they are producing nitric oxide, which is causing dilatation of the efferent arteriole, and they are releasing renin, which is going into the circulation, activating the angiotensin, renin-angiotensin mechanism, eventually resulting in increased angiotensin 2, which goes and constricts the efferent arteriole. Okay, so this constricts. Now, once the efferent arteriole constricts, because of this, what ends up happening? More blood is going into the glomerulus, less is going out. So, as a result, more increase in the glomerular hydrostatic pressure occurs, which increases the GFR further. Okay. Now, initially, this is a compensatory mechanism because it is increasing GFR. But as the number of glomeruli decrease and this RAS activation continues to happen, we will see how that becomes maladaptive. Okay. So, along this increase in systemic hypertension, the efferent arterial constriction and the afferent arterial dilatation, all three result in increased pressure within the glomerulus. So, what we call intraglomerular hypertension. Now, intraglomerular hypertension causes two things. Okay, now there is within the glomerulus, because there is increased hydrostatic pressure, the glomerulus, the podocytes within the visceral podocytes within the glomerulus actually have to support the basement membrane. So, because of, for that, the hypertrophy become larger in size and to provide more mechanical support. Okay, and then this hypertension and podocyte hypertrophy have secondary effects. Eventually, podocytes are not able to hypertrophy or become any larger, and eventually they fail. Okay, so there is podocyte failure, and they start producing non-collagen type 4. So the normal glomerular basement membrane contains collagen type 4 that gets replaced by collagen type 3 and 1. Okay. Now, thing with 3 and 1 is they are not as they don't have as many glycoprotein. They're not attached to as many negatively charged carbohydrate moieties. So as a result of that, there is loss of the glomerular negative charge that we discussed earlier. Okay. Now, because of this, there is proteinuria, and here the proteinuria is non-specific because it is under increased pressure, and there is significant glomerular basement membrane sclerosis. Now, this eventually in on histopathology gives us the entity called focal segmental glomerulosclerosis, which we'll talk about in the next discussion. And together, eventually this results in progression to CKD, which again we'll be coming to our discussion in our discussion on CKD. Okay, itself. Now, FSGS most commonly occurs due to six causes that I recall using the mnemonic SOLAR. Okay, so SOLAR is S for sickle cell anemia. O stands for a disease called oligomeganephronia, where the nephrons are fewer in number but individually much larger in size. This is due to a specific mutation in a gene known as FAN1, which is it encodes for a protein that is involved in double-stranded DNA damage repair. Now, L is loss of nephrons due to anything. That is, like we discussed, obesity, primary glomerular disorder, systemic disorders like diabetes, hypertension. A stands for Alport syndrome. And this is very important. Alport syndrome can eventually result in FSGS. R stands for reflux nephropathy, and again stands for radiation nephropathy. Okay, so radiation nephropathy is not very clinically relevant to an internist, but otherwise, yes. Now, there are two other causes. Hypertension I've already discussed. There is recurrent cholesterol embolization also. Okay. Now, FSGS may be the final outcome of any type of glomerular injury. Okay. So, FSGS can be part of, yeah, so it could be second, it can be a progression of membranous GN. It could be a progression of diseases that normally result in nephritic syndromes, that is like SLE, IgA nephropathy, cryoglomerular nephropathy, and ANCA vasculitis, which we'll come to in subsequent discussions. And it can also be the result of glomerular vascular disorders like microangiopathy, hemolytic anemias. Now, see, collapsing variant is a separate histological variant of FSGS, and it has its very specific causes, and we'll be discussing those causes. I recall them using the mnemonic gambles, and we'll just get to that. Okay. Then it can be due to renal ischemia, viral infections, and drug exposure. Okay. So now coming to our causes of steroid resistant nephrotic syndrome. So basically, what we need to understand is that when we treat nephrotic syndrome patients, generally clinically, we give them empirical steroid therapy, and if obviously the defect is not immunologically mediated and it is not minimal change disease, then these patients don't respond to steroids and they get classified clinically as having steroid resistant nephrotic syndrome. So a lot of these patients are actually have monogenic defects in various proteins involved in the process of maintenance of your the podocyte glomerular basement membrane endothelial barrier, and we'll just go through them because for the sake of completion, by no means do you need to remember this. Okay, so the first type of protein that may be defective that I've seen shown here in this diagram are the proteins that part of the slit membrane, that is the space in between the two podocyte foot processes here. Okay, so these proteins include NHS1, NHS2, and CD2AP. There are others, we'll just get to that. Now, the second group of proteins are ones that connect these proteins that are part of the glomerular slit membrane to the cytoskeleton of the podocyte. So, those include proteins like alpha-actinin 4, IFN2, and myosin heavy chain 9. Okay. The third group of proteins include proteins that connect the cytoskeleton of the podocyte membrane to the glomerular basement membrane itself. So that includes your proteins like the alpha 4 integrin and beta 3 subunit of integrin, as well as a protein known as LAMP2. Okay, right. Now, the defect may be more upstream. That is, it may be a defect in the transcription factors that are expressed by normal podocytes. So those include WT1, that is defective in your WT1 syndrome, LMX1B, which is defective in your nail patella syndrome, and SMARC-L1, which is a protein that we'll discuss when we discuss adrenal insufficiency. The causes of adrenal insufficiency. Then other transcription factors like WDR73, XPO5, NUP93, as well as NUP107. Again, 93 plus 107 is 200, and NUP 205. Okay, so these are the transcription factors. Now, there can also be mitochondrial disorders that are defective because podocytes require a lot of energy to do their normal functions. So mitochondrial dysfunction can be the result of defects in these four specific genes that have been described. Now that includes PDSS2, ADCK4, coenzyme Q2 and 8, and as well as MPTL1. Okay, this diagram is, um, this is a very exhaustive diagram. You need not remember all of this, but as you can see, these are the proteins that have been described as being defective, and all of them localized to the podocyte. So, in steroid resistant nephrotic syndrome, which is monogenic, the patients basically have a problem in their the proteins that are involved in normal podocyte function, and that results in this. Now, in addition to this, you can also have other actin regulatory protein defects, which maybe you can take a screenshot and go through them, and you can have defects in other proteins part of the glomerular slit membrane as well. Okay. Now, obviously, nobody can remember that exhaustive list. So, what I do clinically is I clinically divide it into the syndromes with which it might come. Okay. So, it may be a syndromic presentation like in Fabry's disease that has alpha galactosidase deficiency. Technically not a type of FSGS, but it looks very similar to FSGS. Okay, Wilms syndrome, which is autosomal recessive and WT1 mutated. Now, non-syndromic associations, like I said, again can be autosomal dominant, autosomal recessive, or mitochondrial. Now, when it is autosomal dominant, it is WT1. When it is alpha-actinin 4, IFN2, and TRP6, C6. Now, importantly, WT1 occurs in childhood. Alpha-actinin 4 can present with at any page at any age of the patient, and IFN2 is typically in adults. Then NPHS1, that is congenital nephrotic syndrome, which is called Finnick type. NPHS2 is called is childhood congenital nephrotic syndrome. CD2AP is very severe and presents at an age less than 6 years. And then we have the epsilon 1 subunit of phospholipase C. And then in mitochondria, we have the mitochondrial tRNA gene for leucine, that is UUI. So now this is a topic that I really like to discuss because it's clinically has very specific causes and allows for, you can diagnose it, you're suspected even before doing a biopsy. Now, uh, there are three histological variants of, or four actually, variants of for FSGS, and we'll be discussing the morphologies of this in the next discussion. They're basically the endocapillary variant, the collapsing variant, and the tip variant. There's also a hilar variant, which is same as FSGS, not otherwise specified. Now, the variation in pathogenesis in endocapillary and hypercellular FSGS is that it is secondary to a immunological process. So there is an immunological cell infiltrate resulting in increased cellularity in the glomerulus. In collapsing variant, the pathogenesis is completely different. Okay, that the primary pathogenetic process causes epithelial to mesenchymal transition. Actually, podocytes, the visceral podocytes actually leave their normal function and convert back into mesenchymal cells. Okay, and this forms subcapsular bridges interconnect, and as a result, the normal podocyte function of keeping the glomerular tufts in place that is lost and the collapse. Um, Finally, because of that, there is epithelial collapse. Now, tip variant is the least, serious of these three morphological variants, and is said almost always due to increased transmission of increased systemic pressures into the glomerular tip. Now, endocapillary proliferation variant is like membranoproliferative gene, so it's a morphological and pathophysiological continuum. But importantly, it is immunoglobulin negative. So it like MPGN, it is associated with heavy proteinuria. FSGS is associated with HIV classically, but there are other causes which we'll come to. Tip variant has no specific associations. Collapsing variant has very poor prognosis, almost everybody progressing to CKD, whereas endocapillary proliferation or hypercellularity variant has an intermediate prognosis, and tip variant has a very good prognosis. Now, the collapsing variant is, I don't really like calling it a variant of FSGS. It should be collapsing glomerular nephropathy should be a separate topic itself. Okay. However, we'll just discuss why it is different. So again, I have shown you the two podocytes here. I've colored them differently, not in order to show how they, mesh their food process and mesh into each other and produce the slits that we talk about around the capillary. Okay. Now, what is happening here is first ischemia, that is due to obstruction, say, of that capillary bed. Okay, or due to usage of heroin, atherombolism of the kidney, thrombotic microangiopathies, or sickle cell anemia, results in podocyte ischemia, and that podocyte ischemia results in some transcriptional abnormalities in the podocyte, and this can also happen due to genetic defects in the four genes. Okay, which I remember using a specific mnemonic, which I'll come to. The four genes are myosin heavy chain 9, apolipoprotein L1, WT1, and coenzyme Q. Okay. Now, this results in decreased expression of WT1 transcription factor, which is the master transcription factor of podocytes, as we've just seen, and that causes podocyte to convert from epithelial cells into mesenchymal cells, and therefore leave this basement membrane completely. As a result, completely destroying the structural integrity of the glomerulus. This can also happen. Okay, so as I've just discussed, WT1 expression in podocyte maintains them in a terminally differentiated epithelial state with decreased expression of telomerase and maintains the expression of all of the proteins that are involved in the maintenance of the glomerular slit membrane. Okay. Now, if there is IgA nephropathy, antibody deposition in the mesangium secondarily causes activation of the mesangial cells, which secrete mediators that can also cause this kind of a transition. Now, like I discussed earlier, the mnemonic I use is Gambles. So here, these are the autoimmune disorders that produce either interferon alpha or beta or interferon gamma, and then cause this kind of secondary change in podocytes. So Gambles, G stands for giant cell arteritis, A stands for adult onset Still's disease, M stands for mixed connective tissue disease, B stands for Behçet's disease, L stands for low counts. Now, specifically, this stands for HLH or phagocytic lymphohistiocytosis. Uh, E stands for elevated counts. Now, when I say elevated counts, I mean three malignancies. That is multiple myeloma, ALL, and NK cell leukemia. And S stands for SLE and Sjogren syndrome. So, these are important causes, and you need to recall them because when the biopsy comes, you need to know whether it is primary or secondary because maybe treatment of the primary cause in primary cases may help. Okay, so there are some drugs that can have the same effect like anabolic steroids, bodybuilders. Okay, A, B, C, D I use. So B stands for bisphosphonate, C for anticonvulsants, and D for doxorubicin, which is anthracycline. That is in patients who are getting chemotherapy. So the mnemonic I use actually is hastily mock any man that who gambles. Okay. Now what does haste? Haste is H for heroin, A for atheromembolic disease, S for sickle cell anemia, and T for thrombotic microangiopathy. That is the four causes that cause ischemia of the glomerulus. Okay. Uh, Mock is the four genetic causes that we've just discussed. Gambles we've already discussed is giant cell arteritis, your adult on Still's disease, MCTD that is mixed connective tissue disorders, Behçet's disease, adult your low counts that is specifically HLH, E for elevated counts that is your three malignancies. So man is those three malignancies, and S stands for SLE Sjogren syndrome. So as you can see, there are very specific causes of your collapsing variant of FSGS. It is pathophysiologically very, very different from normal FSGS. Okay. So I like to actually consider it as a separate disease entity altogether. Okay. Now, finishing off with the clinical correlates of these diseases. So we've got membranous disease, we got minimal change disease, and we got focal segmental glomerulonephritis. What is the gender profile and age profile? So membranous is more common in men overall, 2:1 ratio. Uh, it occurs in adults 30 to 50 years of age. It is rare in children, but like we discussed, when it does occur in children, there is a specific antibody association that is semaphore 3B. Okay, and that is anti-semaphore 3B. But it is a cause of nephrotic syndrome in elderly. And again, like we just discussed, there are many causes of secondary MGN. That is almost 70 to 80% of membranous GN are secondary. So whenever you have membranous GN, regardless of whether the patient is positive for your plateau antibody, receptor antibody, or your thrombospondin 7, like 17A antibodies, you still have to work them up for secondary MGN. Now, in case of minimal change disease, it is a childhood disease, and focal segmental glomerular sclerosis, it's actually can occur in anybody, so it's almost equal male is to female. More common in African patients, particularly with ApoL1 gene variants. And age is essentially any, but classically we say that FSGS occurs in older people. Okay, because as you grow older, more and more glomerular damage as such accrues. Now, poor prognostic findings that have been clearly defined in membranous GN include the male gender, older patients, hypertension, and persistent nephrotic range proteinuria. These two indicate, progression to your FSGS and CKD. Older age would imply that there is a possible malignancy underlying, so poor prognosis, and male gender is just otherwise associated. Now, additionally, as you've already seen, the presence of the titer of the plateau receptor antibody and the selectivity of proteinuria, that is the amount, the ratio of serum IgG, so urinary IgG by serum IgG to serum urinary transferrin to serum transferrin being more than 0.2, or the absolute loss of immunoglobulin in urine being more than 250 international units per ml. Both are important prognostic factors. Okay. Now, focal segmental glomerulosclerosis is worse if the patient has features of renal failure. So, renal insufficiency, hypertension, and nephrotic range proteinuria. So, what is common between membranous and FSGS with poor prognosis is higher the proteinuria, more the degree of progression. And it will become very clear when we discuss the pathogenesis of CKD. So, that brings us to the end of our discussion on the the types of causes of these the three types of pathologies that result in nephrotic syndrome, that is your membranous GN, minimal change disease in FSGS, and we've seen that membranous GN in up to 80% cases is secondary, and there are so many causes of secondary. And even in primary, there are two primary antibodies that you need to know about, and I have discussed some all of the new antibodies that are there also. That is a relatively higher level concept. And see, even minimal change disease can be secondary. And finally, FSGS almost always is due to that SOLA, it is your sickle cell anemia, oligomeganephrosis, your this thing, reflex nephropathy, that as I discussed earlier. However, FSGS can also be genetic, and that then presents at a younger age. And you do need to remember which are the autosomal dominant, autosomal recessive, and mitochondrial causes, as well as the two syndromic causes that we have discussed. Then I've tried to highlight how collapsing variant of FSGS is actually a different type of disease altogether. And that is something that is a very important concept to understand. And the pathophysiology is different, the associations are different. Okay. So in the next discussion, we'll be discussing the histopath of these disorders. And I look forward to seeing you there. And that will be a very short discussion. I have discussed most of the clinical correlates and everything here. That will just be purely histopath. So thank you for watching, and I'll see you next time.